Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. The field of pharmaceutical development has been significantly transformed by advancements in biotechnology. This progress has led to the rapid growth of large, complex biopharmaceuticals, commonly known as biologics, which are now the fastest expanding category of new medications. These sophisticated molecules include therapeutic proteins and peptides, such as monoclonal antibodies, as well as nucleic acid-based drugs like gene therapies and antisense oligonucleotides. The complexity and diversity of these biologics present unique challenges that require specialized pharmacological considerations. Developing and administering these advanced treatments demands a comprehensive understanding of their intricate properties and behaviors to ensure their safety and efficacy. Unlike chemically stable small molecule drugs such as aspirin, which weigh approximately 180 daltons, biologics like infliximab, which weighs around 149,000 daltons, present significant pharmacokinetic challenges. These challenges stem from their large size, complex structural hierarchy, and inherent instability. It is critically important to maintain their specific primary, secondary, tertiary, and quaternary structures because degradation by endogenous enzymes, such as proteases and nucleases in the plasma or gastrointestinal tract rapidly leads to a complete loss of their functional activity. As a result, parenteral administration, which involves delivering the drug bypassing the digestive system, is typically necessary. Additionally, the substantial size of biologics severely restricts their distribution within the body, often confining them primarily to the vascular space. To overcome these inherent limitations, it is essential to employ advanced strategies that involve chemical modifications, such as attaching polyethylene glycol molecules to drugs, a process known as polyethylene glycolylation. Additionally, sophisticated targeted drug delivery systems play a vital role. These systems use specialized carriers like liposomes, polymeric nanoparticles, and monoclonal antibodies, which act as homing devices. Their purpose is to improve drug transport, reduce clearance from the body, protect the drug from degradation, and restrict its distribution to specific sites within the body. This approach often results in targeting at the second or third order, thereby increasing effectiveness. However, the large size of monoclonal antibodies can limit the efficiency of drug dosing. This size constraint lowers the ratio of active drug payloads to the carrier, which can impact the overall efficacy of the treatment. Effective management of these therapies necessitates a comprehensive understanding of how drugs are processed in the body. While biologic therapies are usually eliminated through mechanisms that do not involve the cytochrome system, the successful use of complex treatment regimens, especially those involving antibody-drug conjugates or combination therapies, relies on managing genetic variability that affects drug response. This variability often stems from genetic differences in enzymes responsible for drug metabolism, such as cytochrome, P450 enzymes, and phase II enzymes like UDP-glucuronosyltransferases and N-acetyltransferases. Additionally, variations in drug transporters and other key factors, both genetic and non-genetic, must be carefully considered to optimize treatment outcomes. In pharmaceutical education, Mastering the complexities of biopharmaceuticals necessitates specific learning outcomes that connect molecular biology, advanced delivery science, and clinical pharmacogenomics. Students should be able to define and classify biologics, recognizing that they constitute the fastest-growing class of drugs. These include categories such as protein and peptide drugs, like monoclonal antibodies, as well as nucleic acid drugs, including gene therapies. Understanding protein structure and function is essential. Learners should describe the 4 hierarchical levels of protein organization: primary, secondary, tertiary, and quaternary, and explain the importance of maintaining this structural integrity for the therapeutic effectiveness and stability of protein-based medicines. Distinguishing the pharmacokinetic profiles of large biologics from small molecule drugs is also crucial. Large biopharmaceuticals, such as infliximab, have molecular weights of approximately 149,000 daltons, requiring parenteral administration and exhibiting limited distribution within the body, in contrast to small molecules like aspirin, which weigh about 180 daltons. Students should be able to explain why most protein and nucleic acid drugs are too unstable to be administered orally. The rapid degradation caused by endogenous enzymes, such as proteases and nucleases present in the gastrointestinal tract and plasma, contributes to this instability. To overcome these challenges, it is important to identify and understand delivery system strategies. These include chemical modifications like pegylatation and the use of carriers such as liposomes and polymeric nanoparticles, which enhance transport, reduce clearance, and protect biologics from enzymatic degradation. Furthermore, learners should analyze the limitations of antibody-drug conjugates, which combine monoclonal antibodies as targeting agents with therapeutic drugs. Monoclonal antibodies serve as homing devices to deliver drugs specifically to target tissues. However, a physical limitation of antibody-drug conjugates is their low drug-to-carrier ratio, which impacts dosing efficiency, as seen in examples like trastuzumab emtansine. Classifying targeted delivery systems is also important. These systems can be categorized into first-order, second-order, and third-order targeting based on the specificity of the delivery site at the anatomical, cellular, or intracellular level. Additionally, students should be capable of contrasting the mechanisms of action among the 3 main categories of nucleic acid drugs. These include gene therapy, which delivers recombinant DNA, antisense oligonucleotides that modulate splicing, and RNA interference mechanisms that lead to messenger RNA cleavage. Understanding pharmacogenomics is vital when considering complex therapies. Students should be able to summarize the clearance pathways for large biologics that are independent of cytochrome P450 enzymes and justify the importance of pharmacogenomic considerations related to these enzymes, especially when administering co-therapy with small molecule drugs or managing the toxicity of drug payloads in antibody-drug conjugates. Finally, recognizing key intrinsic factors such as disease state and inflammation, along with extrinsic factors like environmental influences, is essential. These factors significantly affect drug metabolism and disposition, emphasizing their role in the effective management of therapeutic regimens involving both biologics and small molecules. The field of biotechnology has significantly transformed the development of pharmaceuticals. It has shifted the focus from relatively simple small molecule drugs to large, intricate biological medicines, often called biologics. These advanced molecular techniques have enabled the creation of sophisticated molecules that hold tremendous potential for treating diseases in ways that were previously impossible. Biotechnology is defined as the use of biological materials to produce specific products, and in this context, it involves creating pharmaceuticals. Today, this sector has become an essential part of the pharmaceutical industry. It also represents the fastest-growing category of new drugs available on the market. Protein and peptide drugs are large molecules known as macromolecules. Their size and complex structure present significant challenges throughout their life cycle, from manufacturing to clinical administration. The three-dimensional structure of these drugs is critically important because it directly influences their pharmacodynamic activity. This structure is organized into multiple levels, each essential to understanding the drug's function. The primary structure refers to the specific linear sequence of amino acids in the chain of the protein or peptide. The secondary structure describes the local folding patterns of the protein backbone, such as alpha helixes or beta sheets. The tertiary structure involves the overall three-dimensional shape of a single protein chain, determined by the arrangement of the secondary structures. Lastly, the quaternary structure pertains to how multiple protein subunits are oriented and assembled to form the complete protein complex. The necessity of maintaining this complex structure presents significant design and manufacturing challenges for biopharmaceuticals. Stability and reproducibility are critical aspects of biologic drugs, which are derived from biotechnology. These drugs must be designed so that their specific structures, including primary, secondary, tertiary, and quaternary conformations, remain stable, reproducible, and accurate throughout the processes of manufacturing, storage, and administration. The process of manufacturing is closely linked to the final product. Even minor changes in the manufacturing process can significantly impact the protein structure, yield, or biological activity, often more so than alterations in the primary amino acid sequence. Due to the high sensitivity of biologic drugs to manufacturing variations, pharmaceutical quality controls and testing procedures need to be meticulously designed, carefully managed, and continuously monitored. These measures must be capable of detecting even subtle chemical or structural changes that could undermine the safety or effectiveness of the product. The complex structures of protein drugs make them susceptible to various forms of degradation that can lead to a loss of activity. Changes in the quaternary structure, such as the aggregation or disaggregation of the protein, may result in the loss of therapeutic activity, although less likely to be immediately affected by process changes. Alterations in the primary structure include deamidation of amino acid chains, oxidation of chains with sulfhydryl groups, and cleavage by proteolytic enzymes present throughout the body. These structural changes complicate the already challenging task of designing, evaluating, and improving the stability of protein and peptide drugs compared to conventional small molecule drugs. Unlike small molecules, proteins face significant stability challenges within the body. These challenges necessitate the use of specific delivery methods to ensure their effectiveness. Biologic drugs, which are composed of proteins, are particularly known to be unstable in the plasma, and especially in the harsh environment of the gastrointestinal tract. Due to their instability, most biologic drugs cannot be administered orally. Instead, they typically require parenteral routes of administration, such as injections into the muscles or directly into the bloodstream. Researchers are also continually exploring alternative methods of delivery, including inhalation and intranasal administration, to improve the stability and convenience of biologic drug delivery. Degradation of protein and nucleic acid drugs occurs rapidly once they enter the body. These drugs are broken down by endogenous enzymes, specifically proteases and nucleases, which are present in the serum, tissues, and cells. Many early recombinant protein drugs had very short half-lives, often measured in minutes. Examples of such drugs include alteplase and interleukin-2. Protein molecules are typically large and hydrophilic. This characteristic limits their ability to reach certain tissues through diffusion and paracellular transport pathways, which small molecules can easily access. As a result, the volume of distribution for larger proteins and nucleic acid drugs is often small, sometimes close to the volume of plasma. This is because these drugs tend to be confined within the vascular space or bind only to specific tissues. Bioequivalence refers to the comparison of two drugs to determine if they have similar bioavailability and effect. Since the quality of a pharmaceutical product, including microheterogeneities such as the degree of glycosylation and post-translational modifications, depends on the manufacturing process, even genetically identical recombinant drugs can differ. These differences can arise due to variations in the cell clone used, the purification process, storage conditions, and formulation techniques. This variation highlights how structural characteristics inherent to the production system can influence the drug's bioavailability, potential immunogenicity, adverse reactions, and overall efficacy. For example, glycosylation, a common post-translational modification, significantly impacts the pharmacokinetics, stability, and effectiveness of drugs such as interferon beta 1A and interferon beta 1B. Glycosylation enhances water solubility and increases molecular weight, which can alter how the drug behaves in the body. To address challenges related to the stability and delivery of biologic drugs, new delivery systems are being actively developed and utilized. These systems include various drug carriers such as conjugates, nanoparticles, liposomes, and viral vectors. The primary goal of using these carriers is to enhance the properties of biologics within the body. Specifically, they aim to improve the transport of the drugs to their target sites, reduce the rate at which the drugs are cleared from the body, and protect the drugs from being broken down or degraded before reaching their intended location. Chemical modification of drugs often involves covalently binding the drug to a carrier molecule. For instance, polyethylene glycol conjugation, also known as pegylation, is used to enhance the clearance of certain drugs such as adenosine deaminase and filgrastim, a medication marketed as Neulasta. This process allows the drug to bypass the kidney's filtration system, thereby extending its circulation time in the body. Additionally, modifying large proteins to bind to the body's own albumin can significantly prolong their half-lives. An example of this approach is the insulin formulation marketed as Levemir, which benefits from this modification to maintain its effectiveness over a longer period. Liposomes are lipid bilayer vesicles capable of encapsulating drugs, which helps reduce side effects such as cardiotoxicity caused by the chemotherapy drug doxorubicin. These vesicles can be engineered to target specific sites within the body, sometimes by incorporating targeting agents such as monoclonal antibodies. Additionally, stealth liposomes are coated with polyethylene glycol, a process that allows them to evade detection by phagocytes and the reticuloendothelial system. This evasion enhances their circulation time in the bloodstream and extends their half-life. Polymeric systems involve the attachment of polymers to drugs, either through covalent or non-covalent bonds. This modification can enhance the physical characteristics of the drugs, such as increasing their solubility or improve their pharmacokinetic properties. Polymers with molecular weights exceeding 30 to 50 kilodaltons are typically too large to pass through the glomerular filtration in the kidneys, which allows them to extend the circulation time of the drugs in the bloodstream. Nanoparticles and microparticles are biodegradable particles made from polymers or lipids that are used to encapsulate therapeutic agents. Due to their small size, they can penetrate tissues effectively, offer protection against degradation, and enable a sustained release of the therapeutic agents. These nanoparticles are believed to accumulate preferentially in cancerous tissues through a phenomenon known as the enhanced permeation and retention effect, which allows for targeted treatment. Targeting agents, specifically monoclonal antibodies, are protein-based drugs that serve as precise delivery tools because of their ability to bind to a single specific antigenic determinant. These antibodies can be directly linked to toxins or cytotoxic drugs, creating what are known as antibody-drug conjugates. For example, drugs like brentuximab vedotin and trastuzumab emtansine are designed to deliver therapy directly to target cells. Such targeted therapies are particularly useful in treating cancers that express unique surface markers. An example is Herceptin, which binds to the HER2 protein found on breast cancer cells. Protein drugs are medications that utilize naturally occurring products in the body to prevent disease or maintain health. They often work by supplementing insufficient production of certain proteins or by providing higher than normal levels of these proteins. There are several main therapeutic applications for these recombinant protein products. Recombinant therapeutic proteins are used to compensate for deficiencies or to modulate specific biological pathways. These products are essential in treating various diseases caused by insufficient production of natural proteins. For example, patients with insulin-dependent diabetes are treated by supplementing their bodies with recombinant human insulin, such as Humulin. Similarly, recombinant human growth hormone, marketed as Protropin or Neutropin, is administered to address growth hormone deficiency. Additionally, the enzyme glucocerebrosidase, available under the names Ceridase or Cerezyme, is used to treat Gaucher's disease. In the area of immune system modulation, interferons and interleukins play significant roles. Interferons are naturally produced by the immune system in response to viral infections, and they are used to enhance immune responses against various conditions. Interleukins, such as aldesleukin or interleukin-2, and other formulations like Raphorin A, Intron A, and Actimmune, are employed to bolster the immune system in cases of viral infections, immunosuppression, cancer, and multiple sclerosis. Hematopoietic and growth factors are also crucial components of recombinant protein therapy. Erythropoietin, marketed as Epigen or Procrit, stimulates red blood cell production and is commonly used to treat anemia. Related growth factors, including filgrastim and sargramostim, target the production of white blood cells and are frequently used to treat immune suppression following chemotherapy treatments. The development of monoclonal antibodies represents a significant advancement in the fields of biotechnology and complex pharmaceuticals. This innovation has led to a fundamental shift in the pharmaceutical industry, transitioning from relatively simple small molecule drugs to larger, more sophisticated, and complex therapeutic agents. Biopharmaceuticals, also known as biologics, are produced using biological materials. The fastest-growing segment within this market includes nucleic acid, peptide, and protein-based drugs. Monoclonal antibodies are a specific type of protein drug. Their defining characteristic is the ability to bind highly specifically to a single antigenic determinant. This unique feature makes monoclonal antibodies a powerful and distinct class of protein drugs, useful in various applications such as therapy, diagnostics, and targeted treatment in modern medicine. Monoclonal antibodies are a type of biopharmaceutical drug product that relies on the body's natural immune response machinery. The significance of their specificity is highlighted by contrasting them with naturally occurring polyclonal antibodies. A binding site is the specific region on an antigen where an antibody attaches. Typically, antigens are composed of protein molecules. However, non-protein materials, known as haptens, can also be attached to proteins to form an epitope. An epitope is the particular part of the molecule that binds to an antibody. The remarkable strength of monoclonal antibodies lies in their ability to bind very specifically to a single antigenic determinant. Unlike polyclonal antibodies, which are mixtures found in serum and are generally considered too impure for modern therapeutic use, monoclonal antibodies are preparations that contain many copies of a single antibody. This specific characteristic enables them to bind to and detect only one antigenic site, ensuring high specificity. By having a uniform structure, monoclonal antibodies provide consistent results in diagnostic and therapeutic applications. In contrast, polyclonal antibodies, due to their heterogeneous nature, may recognize multiple epitopes, which can lead to variability in effectiveness. This distinction underscores the importance of purity and specificity in the development and application of antibody-based treatments and diagnostics. Production of monoclonal antibodies involves a sophisticated technique that combines an antibody-producing spleen cell with a myeloma cell to form a hybrid cell, known as a hybridoma. These hybrid cells are then cloned so that each culture originates from a single cell. This process ensures that the resulting monoclonal antibody is specific to only one antigenic determinant on the original antigen. Additionally, because monoclonal antibodies are often derived from mice, they are frequently modified through genetic engineering to be more similar to human antibodies. This modification, known as humanization, helps to reduce the immune response from patients receiving these therapeutic antibodies. The purity and highly specific binding capability of mAbs make them extremely useful as diagnostics, targeting agents, and therapeutic agents for diseases previously considered untreatable. Monoclonal antibodies are used extensively in cancer treatment. They can either directly neutralize unwanted cells or molecules, or be part of targeted delivery systems. Several monoclonal antibodies have been approved for the treatment of various cancers, including leukemia, lymphomas, and solid tumors. For example, rituximab targets the CD20 protein found on B cells and is used in the treatment of follicular lymphoma and B-cell non-Hodgkin's lymphoma. Trastuzumab is designed to bind to the human epidermal growth factor receptor, which is often overexpressed on metastatic breast cancer tumors. This antibody preferentially binds to breast cancer cells that overexpress this receptor, although it can also bind to some non-cancerous cells that express the same receptor. Additionally, alemtuzumab targets the CD52 protein on blood cells and is used to treat B-cell chronic lymphocytic leukemia. Targeting toxins and drugs using antibody-drug conjugates, ADCs, involves the use of monoclonal antibodies that can specifically target and deliver toxic or highly reactive drugs to cancer cells. This targeted approach destroys the cancer cells while minimizing damage to normal cells, leveraging the high potency and narrow therapeutic range of the cytotoxic drugs. To date, 3 antibody-drug conjugates have received approval from the Food and Drug Administration. These include brentuximab vedotin, used for treating Hodgkin's lymphoma and anaplastic large cell lymphoma, and trastuzumab emtansine, which is used in the treatment of breast cancer. The mechanism of action involves coupling a cytotoxic molecule, such as recombinant diphtheria toxin, to a monoclonal antibody that recognizes a receptor overexpressed by tumor cells. An example of this targeted therapy is denalucan diftitox, which targets the interleukin-2 receptor. Although denalucan diftitox has achieved an overall tumor response rate of 38%, it is associated with side effects such as acute hypersensitivity reactions, occurring in approximately 69% of patients, and vascular leak syndrome, observed in about 27%. Monoclonal antibodies are essential tools in medical diagnostics because of their high specificity. They enable the precise location and visualization of tumors or tissue injuries. For identifying tumors, monoclonal antibodies can be combined with radioactive markers to help clinicians see the tumor's position and size. For instance, Prostacint, also known as caprimab-pinditide, is an imaging agent used specifically for diagnosing prostate cancer. Another example is Verluma or nofetamomab, which is labeled with technetium-99m and used to detect small cell lung cancer. In addition to cancer detection, monoclonal antibodies play a vital role in identifying myocardial injury. Myosint, which contains monoclonal antibodies targeted to myosin and labeled with indium-111, is used for imaging patients suspected of having a myocardial infarction, commonly known as a heart attack. These applications highlight the significance of monoclonal antibodies in diagnosing and assessing various medical conditions. Monoclonal antibodies are vital components in targeted drug delivery systems, often serving as the homing device in complex carrier structures. Active targeting is an approach that employs ligands or monoclonal antibodies to direct drug carriers precisely to specific cells. These antibodies can be conjugated directly to drugs or combined with other delivery systems such as liposomes or nanoparticles, thereby enabling targeted delivery to particular sites within the body. For example, urokinase has been conjugated to an antifibrin monoclonal antibody to dissolve fibrin clots. The carrier system seeks out fibrin sites to activate the conversion of plasmin, which helps break down clots. Similarly, the monoclonal antibody trastuzumab has been utilized as a targeting agent for nanoparticles encapsulating anti-cancer drugs, with clinical studies demonstrating its application. Despite the promise that monoclonal antibodies hold as magic bullets for drug targeting, there are notable limitations. A significant challenge is their large molecular size, which reduces the total amount of active drug that can be administered, effectively decreasing the ratio of drug to carrier. As a result, researchers are testing smaller antibody fragments as alternative options. Monoclonal antibodies play a vital role in immunosuppression to prevent the body from rejecting transplanted organs or tissues. In the case of kidney transplants, an antibody targeting CD3, a membrane protein found on cytotoxic T cells, has been used effectively to suppress rejection. This drug, known as muromonab, CD3, is employed to reverse acute rejection episodes in kidney transplant patients. Other monoclonal antibodies approved for immunosuppression in renal transplantation include basiliximab and daclizumab, which target the interleukin-2 receptor. Additionally, a rabbit-derived antithymocyte globulin, known as thymoglobulin, is utilized for treating acute rejection in renal transplant recipients. Although monoclonal antibodies are highly specific in binding, their use is limited by several pharmacokinetic and delivery challenges. These antibodies are large, complex protein molecules, which creates difficulties in effectively delivering the drug to targeted tissues. Initially, they were hoped to serve as the magic bullet for precise drug targeting, but this expectation has not been fully realized. A major challenge is their large molecular size, which limits the amount of active drug that can be safely administered, thereby reducing the ratio of drug to carrier. Additionally, monoclonal antibodies are complex structures composed of over 1,200 amino acids. Maintaining their structural integrity at all levels, primary, secondary, tertiary, and quaternary, is essential for their function and must be carefully preserved throughout manufacturing, storage, and administration. Furthermore, their large size and hydrophilic nature hinder their distribution across tissues, as they cannot easily diffuse through tissue barriers. As a result, their distribution volume typically approximates the blood plasma volume, confining them mainly to the vascular space or to tissues with high vascular permeability, such as the liver, spleen, bone marrow, and certain tumors. As complex protein molecules, monoclonal antibodies present significant pharmacokinetic and delivery challenges distinct from small molecule drugs. Monoclonal antibodies are large molecules, often consisting of more than 1,200 amino acids. Due to their substantial size and generally hydrophilic nature, these compounds have limited ability to diffuse into most tissues. As a result, their volume of distribution, which indicates the extent to which a drug spreads throughout the body, is typically small. This volume often approximates the plasma volume because monoclonal antibodies tend to remain within the vascular space or bind to specific tissues. Tissues that exhibit higher vascular permeability, such as the liver, spleen, bone marrow, and tumor tissues, have greater access to these large molecules. Aspirin, also known as acetylsalicylic acid, is a small molecule drug commonly used to alleviate pain, reduce fever, and decrease inflammation. Its molecular weight is approximately 180 daltons. In contrast, infliximab, marketed under the brand name Remicade, is a large monoclonal antibody that specifically targets a protein called tumor necrosis factor alpha. This medication is employed in the treatment of autoimmune diseases such as Crohn's disease and rheumatoid arthritis. The molecular weight of infliximab is around 149,000 daltons, making it over 800 times larger than aspirin. The primary challenge associated with the size of monoclonal antibodies is determining how they can effectively enter the body. For comparison, consider aspirin, which is a small molecule. Its small size and chemical stability allow it to be formulated into an oral pill, survive the acidic environment of the stomach, and be easily absorbed through the gastrointestinal tract into the bloodstream. In contrast, monoclonal antibodies such as infliximab are large proteins. If taken orally, these proteins would be treated like dietary proteins, such as chicken, and would be completely digested by enzymes in the stomach and intestines. Consequently, they would never reach the bloodstream in their intact form. To bypass this issue, monoclonal antibodies must be administered via intravenous infusion, which involves injecting the medication directly into the bloodstream. This method is less convenient and more costly, requiring a clinical setting for proper administration. Once in the bloodstream, the ability of different substances to travel throughout the body varies significantly. Aspirin, a small and fat-soluble molecule, can quickly leave the bloodstream and cross cell membranes. This allows it to be widely distributed across the body's tissues and fluids, reaching its targets, which are enzymes located inside cells, more efficiently. This high volume of distribution facilitates its effective action. In contrast, infliximab is a monoclonal antibody with a much larger size. Its large molecular size severely limits its movement within the body. It remains primarily within the blood vessels and the lymphatic system and cannot passively cross cell membranes. Instead, its distribution occurs slowly through convection, which involves fluid flowing into the spaces between cells, known as interstitial spaces. This process means that infliximab has a limited and more restricted distribution in the body. The specific challenge with infliximab involves its target, tumor necrosis factor alpha, which is often concentrated in inflamed tissues such as the joints in rheumatoid arthritis or the lining of the gut in Crohn's disease. For the drug to be effective, it must gradually leak out of the capillaries within these inflamed areas to bind to its target. This slow and limited distribution to the target site presents a significant pharmacokinetic obstacle, a challenge that is not typically encountered with small molecule drugs. Protein drugs are susceptible to rapid degradation by endogenous proteases found in the serum, tissues, and cells. Because these drugs are large and complex molecules, it is essential to maintain their structural integrity, including their three-dimensional structure, to preserve their biological activity. Most biologic drugs are too unstable to be administered orally, and therefore must typically be given through parenteral routes. An example of a protein drug is insulin, which is a relatively small protein molecule known as a peptide hormone. Insulin is crucial for regulating blood glucose levels. Its structure and function exemplify the challenges associated with protein drugs. Insulin consists of 51 amino acids arranged in two chains, known as the A and B chains. These chains are linked by disulfide bonds, which help maintain the molecule's stability. The primary function of insulin is to act as a key that binds to specific insulin receptors on the surface of cells, including muscle, fat, and liver cells. This binding process activates the receptors and signals the cells to absorb glucose from the bloodstream, thereby lowering blood glucose levels. Here's how insulin exemplifies the challenges associated with protein-based drugs. If someone were to swallow an insulin pill, it would be completely rendered useless by the digestive system. This serves as a prime example of how endogenous proteases can cause degradation of such drugs. In the stomach, the highly acidic environment, with a pH ranging from 1.5 to 3.5, would cause the insulin protein to denature. Denaturation refers to the loss of the protein's specific three-dimensional structure. Once unfolded, digestive enzymes present in the stomach and small intestine would attack the insulin. In the stomach, the enzyme pepsin begins cleaving the insulin chains. As the partially digested material moves into the small intestine, enzymes like trypsin and chymotrypsin continue breaking down the insulin. These proteases fragment the protein into small, inactive peptides and individual amino acids. Essentially, the human digestive system treats therapeutic insulin much like it treats proteins from sources such as chicken or beans. Instead of functioning as a drug, insulin is digested for absorption as basic nutrients. The activity of insulin depends entirely on its precise three-dimensional shape. According to the lock and key model, the insulin receptor on a cell surface acts as the lock, while a correctly folded insulin molecule serves as the key. The specific arrangement of amino acids on the surface of the insulin protein enables it to fit perfectly into the receptor's binding site. When proteases, which are enzymes that break down proteins, cleave the chains of insulin, they effectively break the key into pieces. These fragments no longer have the correct shape needed to bind to the receptor. As a result, the signal required to unlock the receptor is never transmitted, and glucose is not transported into the cell. This loss of structural integrity leads to the complete loss of insulin's biological activity. The solution for effective insulin delivery involves bypassing the destructive environment of the gastrointestinal tract and ensuring that the insulin structure remains intact during administration. One of the most common methods is subcutaneous injection, which involves injecting insulin into the fatty tissue just beneath the skin. This route is effective because it allows the insulin molecules to be absorbed slowly and directly into the capillaries, ultimately entering the bloodstream. Once in the bloodstream, the structurally intact insulin molecules, often described as keys, can circulate widely to reach their corresponding locks, the insulin receptors, on target cells. This interaction facilitates the regulation of blood glucose levels. Insulin serves as a quintessential example of a protein drug that is too fragile for oral delivery. It is rapidly degraded by digestive proteases in the gastrointestinal tract and relies heavily on maintaining its complex three-dimensional structure to function properly. Therefore, parenteral administration, such as subcutaneous injection, is necessary to ensure that insulin remains effective. Although monoclonal antibodies act as powerful targeting agents, their large molecular size presents challenges for dosing efficiency. The size of these molecules limits the amount of active drug that can be delivered per dose, effectively reducing the drug-to-carrier ratio. This complexity initially fueled hopes that monoclonal antibodies would serve as magic bullets for drug targeting. However, achieving this ideal proved more difficult than originally anticipated. The example to consider is trastuzumab emtansine, also known as T-DM1, which is an antibody-drug conjugate. This drug is specifically designed to target HER2-positive breast cancer, functioning as a highly targeted therapy often referred to as a magic bullet. Its structure clearly illustrates some of the challenges associated with dosing efficiency in such treatments. T-DM1 is a complex therapeutic agent that combines a monoclonal antibody with a potent chemotherapy drug. The targeting component of this drug is trastuzumab, an antibody that specifically seeks out and binds to the human epidermal growth factor receptor 2, which is often found in excess on the surface of certain breast cancer cells. This monoclonal antibody has an approximate molecular weight of 148,000 daltons, making it a large and significant protein. The active drug part of T-DM1 is DM1, a highly potent cytotoxic agent derived from maytansine. DM1 works by inhibiting microtubules within cells, leading to cell death. Due to its high toxicity, DM1 cannot be administered systemically on its own. Its molecular weight is much smaller, around 738 daltons. This combination allows the delivery of the potent chemotherapy directly to cancer cells, minimizing harmful effects on other tissues. Overall, T-DM1 exemplifies a targeted cancer therapy approach that merges the specificity of antibodies with the destructive power of chemotherapy. The challenge of dosing efficiency is illustrated by the issue of drug-to-antibody ratio. This ratio is limited by chemical and physical constraints, which prevent attaching many payload molecules to the large antibody carrier. As a result, the number of payload molecules that can be attached to each antibody is restricted, impacting overall dosing effectiveness. The drug-to-antibody ratio for trastuzumab emtansine, commonly known as T-DM1, is approximately 3.5. This indicates that for each molecule of the trastuzumab antibody, there are about 3 to 4 molecules of the DM1 payload attached. To better understand the mass imbalance, we consider the mass of the antibody, which is roughly 148,000 daltons. The mass of the payload, calculated as 3.5 molecules of DM1 at 738 daltons each, totals approximately 2,583 daltons. Therefore, the total mass of the conjugate, T-DM1, is approximately 150,583 daltons. This leads to a startling conclusion regarding the ratio between the drug and its carrier. It indicates that more than 98% of the mass of the intravenous drug infusion consists of the antibody carrier, rather than the actual cell-killing payload. For example, a patient receiving a dose of 150 milligrams of the drug trastuzumab demonogam, T-DM1, is only receiving about 2.5 milligrams of the chemotherapy agent DM1, which is delivered in a targeted manner. This example vividly illustrates why the original concept of a magic bullet, first proposed by Paul Ehrlich over a century ago, proved to be so challenging in practice. The hope, or the magic, lies in the ability of monoclonal antibodies to target specific cells. For instance, trastuzumab is highly selective for the HER2 receptor, ensuring that the therapeutic payload is delivered primarily to cancer cells and minimizing damage to healthy tissue. This specificity is indeed the magic behind its effectiveness. However, the reality presents a different picture, often referred to as the bullet problem. The drug used as the payload, which is a potent molecule called DM1, is extremely powerful. Yet, it is very small compared to its delivery vehicle, the antibody. Because of this size discrepancy, the ratio of drug to carrier is inefficient. This means that a very large quantity of the antibody-drug conjugate must be administered to deliver a therapeutically effective amount of the payload into the tumor cells. This challenge highlights a fundamental physical limitation that was not anticipated by early supporters of the magic bullet theory. T-DM1 is a highly effective and successful medication. It consists of a large antibody carrier that is attached to a small but potent payload. This composition illustrates a significant challenge in dosing efficiency, which is primarily caused by the large molecular size of monoclonal antibodies. Because of their size, these antibodies can be difficult to administer efficiently. Nucleic acid-based drugs work by targeting the core genetic processes inside cells, specifically transcription and translation, to produce a therapeutic effect. This category of medications includes various technologies such as gene therapy, antisense oligonucleotides, and RNA interference. These approaches utilize the manipulation of genetic material to treat or prevent diseases effectively. The development of nucleic acid drugs presents unique challenges similar to those faced by other biological medicines. These drugs are large molecules, which can complicate their handling and effectiveness. Additionally, nucleic acid drugs are chemically unstable, making their storage and stability a concern. Their size and chemical nature also pose difficulties for efficient entry into cells and their nuclei, which is essential for their therapeutic action. Overcoming these challenges is crucial for advancing nucleic acid-based therapies. Nucleic acid drugs are composed of deoxyribonucleic acid and ribonucleic acid molecules. Their properties, including size, shape, charge, surface characteristics, and chemical stability, present challenges in the development of these drugs. Understanding these physical and chemical characteristics is crucial for advancing nucleic acid-based therapies. Unmodified nucleic acids, such as DNA and RNA, are highly unstable within the body. They are quickly broken down by natural enzymes called nucleases, which are present in blood serum, tissues, and cells. The half-life of unmodified DNA can be as short as a few minutes, indicating rapid degradation and instability. Delivery requirements for nucleic acid drugs are critical for their effectiveness. These drugs must reach their target site of action, which is often the cell nucleus, and remain structurally intact to function properly. However, nucleic acid molecules are inherently unstable and hydrophilic, presenting significant challenges related to their bioavailability, distribution within the body, and efficient uptake by both cells and the nucleus. To overcome these hurdles, delivery systems such as liposomes or polymeric nanoparticles are frequently employed. These systems enhance the stability of nucleic acid drugs and enable measurable expression, thereby improving their overall efficacy. Gene therapy involves delivering recombinant DNA to somatic cells within the body. This process enables the cell's machinery to produce a therapeutic protein that is encoded by the transgene. The primary goal of gene therapy is to restore a defective biological function or to enhance existing functions. It is particularly used in the treatment of inherited disorders and cancer. The size constraints of the ribosomal DNA construct are an important consideration. This construct must include the therapeutic gene, also known as the transgene, as well as regulatory regions such as the promoter. Typically, the entire construct can be quite substantial, often ranging from 10 to 20,000 base pairs. Designing these constructs requires careful attention to their size to ensure they can be effectively used in genetic therapies. Effective delivery systems, known as vectors, are essential for efficiently delivering therapeutic genes into target cells. These systems must facilitate entry into the cell, transport the gene to the nucleus, and enable the stable and continuous production of functional proteins, all while avoiding immune system reactions. One common approach involves the use of viral vectors. In this method, viral genes responsible for replication are replaced with the therapeutic gene, and the recombinant DNA is packaged into a viral particle. These modified viruses can infect target cells and deliver the gene without causing viral replication, thus allowing gene expression. Another approach is non-viral delivery, which involves inserting the therapeutic gene into a plasmid, a type of naked DNA molecule. While naked DNA can sometimes produce small amounts of gene expression, particularly in cell types like muscle cells, achieving significant expression in other cell types often requires the use of polymeric nanoparticles or lipid-based delivery systems, such as liposomes. There is also a cell-based, or ex vivo, method. This involves removing cells from the patient, such as bone marrow cells, and introducing the therapeutic genes into these cells outside the body. The modified cells are then reintroduced into the patient. This approach has the advantage of avoiding systemic toxicity often associated with viral or non-viral delivery systems. Clinical application of gene therapy has been demonstrated in the treatment of lipoprotein lipase deficiency. One notable product is Glibera, which has been approved for use in the European Union. This therapy involves incorporating the gene responsible for lipoprotein lipase into a recombinant adeno-associated virus, facilitating gene delivery and expression. A notable example of in vivo somatic gene therapy is Zolgensma, also known by its generic name onasemnogene abuparvovec. This treatment is specifically designed to address spinal muscular atrophy, a severe inherited neuromuscular disorder that affects muscle strength and movement. By delivering a functioning copy of the defective gene, Zolgensma aims to improve the health outcomes for individuals suffering from this debilitating condition. The inherited disorder known as spinal muscular atrophy is caused by a mutation or deletion in the gene responsible for producing survival motor neuron protein. This defective gene prevents the body from generating sufficient amounts of the essential protein. The survival motor neuron protein is critical for the survival and proper functioning of motor neurons. When the production of this protein is inadequate, motor neurons in the spinal cord die off. This degeneration leads to progressive muscle weakness, paralysis, and, in the most severe cases, death. The primary therapeutic goal is to restore the body's ability to produce functional survival motor neuron protein within the patient's own motor neurons. Achieving this aims to halt the progression of the disease. Zolgensma accomplishes its therapeutic effect through a series of carefully designed steps. The core component of the treatment is a piece of recombinant DNA, which is a synthetic, functional copy of the human survival motor neuron 1 gene. This piece of DNA, known as the transgene, is responsible for producing the necessary therapeutic protein. The therapy is administered as a single, one-time intravenous infusion directly into the patient's bloodstream. The recombinant DNA is packaged within a viral vector, specifically a modified, non-replicating adeno-associated virus type 9. This viral vector is selected for its ability to cross the blood-brain barrier and deliver its genetic payload to the target cells, particularly the motor neurons within the central nervous system. Once the viral vector reaches the motor neurons, it delivers the survival motor neuron 1 gene into the nucleus of these cells. The gene remains as a stable, circular piece of DNA, called an apiosome, inside the cell. The neuron's natural cellular machinery then reads the new gene, and through processes known as transcription and translation, it begins to produce the functional survival motor neuron protein continuously. This production of the survival motor neuron protein restores the function that was lost due to a defective native gene. As a result, the motor neurons can survive, operate properly, and maintain communication with the muscles. For patients, this means the preservation of motor functions, enabling developmental milestones such as sitting up or walking that might otherwise be impossible. Ultimately, this therapy significantly improves the chances of survival and quality of life. Antisense drugs are based on short DNA or RNA sequences called oligonucleotides, which are designed to block specific genetic pathways. These drugs work by binding complementarily to target messenger RNA sequences, which are known as the sense strand. This binding inhibits the translation process, preventing the production of the corresponding protein. To enhance their stability within the body, chemical modifications are often introduced into the oligonucleotides. A common modification involves substituting sulfur for oxygen in the phosphate backbone of the molecule, resulting in phosphorithiode-derived antisense oligonucleotides. These modifications help improve the durability and effectiveness of the drugs. Delivery and targeting. Although oligonucleotides are relatively well internalized by cells compared to larger ribosomal DNA molecules, the cellular uptake is often low enough to require delivery systems such as liposomes. Antisense drugs have been designed to target viral diseases and cancer cells. An example of this is Vitravine, which targets cytomegalovirus and was the first antisense drug approved by the Food and Drug Administration. Other approved intravenous antisense drugs include alicoforsin and mipomersin. Additionally, Mecugen is an oligonucleotide that has been used as a drug, although it is more costly compared to alternatives. Nusinersen, sold under the brand name Spinraza, is an antisense oligonucleotide drug that has revolutionized the treatment of spinal muscular atrophy. This condition is a severe genetic disorder that affects muscle strength and movement. Nusinersen works by manipulating the cellular machinery in a clever way to increase the production of functional protein from the SMN2 gene, which acts as a backup. As a result, it provides a significantly improved quality of life for patients with this disorder. This is how nusinersen works. Nusinersen is a type of medicine known as an antisense oligonucleotide, which means it is a short, synthetic strand of modified nucleic acids. It is specially designed to resist breakdown by enzymes in the body, allowing it to last much longer than natural RNA. This medication helps address a genetic problem related to the survival of motor neurons. The main issue it targets involves the process of alternative splicing in the messenger RNA produced from the SMN2 gene. During this process, a region called an intronic splicing silencer causes a critical part of the genetic code, known as exon 7, to be skipped. When this happens, the resulting messenger RNA is shorter and produces a fragile, non-functional version of the SMN protein. Nusinersen works by binding to this silencer region on the messenger RNA. It is administered through an injection into the spinal fluid. The medication is designed to be an exact match to the silencer region, so it attaches tightly and blocks it physically. This action prevents the splicing machinery from recognizing the skip signal. As a result, exon 7 is included correctly in the messenger RNA. This leads to the production of a full-length, stable, and functional SMN protein. The increase in this protein helps compensate for the deficiency caused by the missing or defective SMN1 gene, supporting the survival and proper functioning of motor neurons. RNA interference molecules are powerful and precise inhibitors of gene expression, functioning similarly to antisense oligonucleotides. These molecules can be either single-stranded, such as microRNAs, or double-stranded, known as small interfering RNAs. Small interfering RNAs work by binding to complementary sequences on target messenger RNA molecules, which results in the degradation of the messenger RNA. This process is mediated by a complex called the RNA-induced silencing complex, which plays a crucial role in the gene silencing mechanism. The action mediated by RNA interference provides an advantage over antisense molecules because a single small interfering RNA molecule can degrade multiple target messenger RNA molecules upon activation. This technology is important for two main reasons. First, microRNAs may contribute to the development of diseases and could serve as targets for therapy. Second, small interfering RNAs are highly potent molecules that can inhibit gene expression effectively. Currently, drugs based on RNA interference are undergoing clinical testing for various conditions, including cancer, viral infections, and heart diseases. RNA interference drugs encounter challenges similar to those faced by antisense oligonucleotides, particularly in terms of stability and delivery. To address these issues, similar chemical modifications and delivery technologies are required to ensure effective transportation and functionality of these drugs. The mechanism of RNA interference, as exemplified by the drug patisiran, represents a significant breakthrough in biological therapy. Patisiran, marketed under the brand name Onpattro, was the first small interfering RNA drug to receive approval for medical use. It provides a clear demonstration of how RNA interference functions as a novel treatment approach. Patisiran is specifically used to treat a rare genetic disorder known as hereditary transthyretin-mediated amyloidosis. This condition arises when a mutation in a gene causes the liver to produce an abnormal form of a protein called transthyretin. Normally, transthyretin helps transport vitamin A in the bloodstream, but in this disease, the mutated protein becomes misfolded and unstable. As a result, it accumulates as amyloid fibrils in various tissues of the body, leading to severe damage to the nerves and heart organs. The goal of patisiran is to prevent the production of the harmful transthyretin protein at its source, which is the genetic message within liver cells. Patisiran works through a specific mechanism involving a small interfering RNA molecule. This molecule is a short, double-stranded RNA designed with a sequence that precisely matches a particular section of the messenger RNA responsible for coding the transthyretin protein. To ensure its protection and facilitate delivery to the liver, the small interfering RNA is encapsulated in a lipid nanoparticle. Once the nanoparticle is absorbed by a liver cell, it releases small interfering RNA into the cytoplasm. In this environment, the cell's natural RNA interference machinery takes over. The double-stranded small interfering RNA is recognized and loaded into a protein complex called the RNA-induced silencing complex. Within this complex, the small interfering RNA is unwound, and one strand, the guide strand, is retained. The activated RNA-induced silencing complex, now programmed with the guide strand, functions as a highly specific search tool. It patrols the cell and binds to any messenger RNA molecule that has a sequence perfectly complementary to the guide strand. In this case, it targets only the messenger RNA responsible for producing a specific protein. Once bound, an enzyme within the complex, called argonaute, precisely cleaves or cuts the messenger RNA, preventing it from producing its associated protein. The outcome of this process is that the genetic message, or messenger RNA, for the transthyretin protein is effectively rendered useless. The process involves a specific cleavage that causes the messenger RNA to be rapidly degraded by the cell. As a result, the messenger RNA can no longer serve as a blueprint for producing the transthyretin protein. This targeted destruction allows the drug patisiran to specifically and powerfully silence the gene responsible for producing transthyretin, thereby reducing its levels in the body. This is where the comparison to antisense oligonucleotides is particularly relevant. The drug inotersen, which is an antisense oligonucleotide, is also used to treat hereditary ATTR amyloidosis by targeting transthyretin messenger RNA. Both patisiran, which employs the RNA interference mechanism, and inotersen aim to prevent the translation of transthyretin messenger RNA, thereby lowering the levels of the disease-causing protein. In this respect, they are functionally similar. However, their cellular mechanisms differ significantly. Patisiran, as a small interfering RNA, leverages the cell's natural, enzyme-driven RNA-induced silencing complex pathway to locate and cleave messenger RNA. In contrast, inotersen is a synthetic single-stranded DNA molecule that binds directly to transthyretin messenger RNA, forming an RNA and DNA hybrid. This hybrid attracts an enzyme called ribonuclease H, which then degrades the messenger RNA. The development and implementation of targeted drug delivery systems are crucial aspects of modern pharmaceutical science. These systems are particularly important in the context of complex drugs, such as biopharmaceuticals, and highly potent small molecule drugs. Their primary goals are to maximize therapeutic efficacy while minimizing toxicity to non-target areas. Targeted drug delivery systems are designed to address the inherent challenges associated with the disposition of drugs within the body. They ensure that therapeutic agents reach their intended site of action in an effective and safe manner. Targeted drug delivery, also known as site-specific drug delivery, involves the use of drug carrier systems designed to deliver the therapeutic agent directly at or near the receptor site. This focused approach aims to confine the distribution of the drug exclusively to the intended site, which helps prevent exposure of the drug to other tissues and reduces adverse toxicity. For biopharmaceuticals, achieving selective and targeted delivery is especially important, as it can significantly lower toxicity levels, reduce the required dosage, and decrease overall treatment costs. Targeted drug delivery can be classified into three main categories, which range from broad physiological targeting to highly specific cellular localization. The first level involves delivering the drug primarily to the capillary bed of the targeted organ or tissue, ensuring concentrated delivery to the general area of interest. The second level of targeting is more precise, focusing on delivering the drug to a specific type of cell, such as tumor cells, while avoiding neighboring normal cells. The most advanced level of targeting is highly specific, involving the delivery of the drug directly to an internal site within the cell. An example of this is receptor-mediated entry, where the drug complex is transported into a cell through a process called endocytosis, and then the drug is released within the lysosome inside the cell. Targeting can be characterized based on the underlying mechanism. Passive targeting exploits the natural disposition profiles of a drug carrier, which are determined passively by the carrier's physicochemical properties relative to the body's anatomical and physiological characteristics. This means that the distribution of the carrier within the body occurs naturally, guided by its inherent properties. In contrast, active targeting involves modifying the natural disposition of the carrier system to direct it towards specific organs, tissues, or cells. This is often achieved by employing targeting agents such as monoclonal antibodies or ligands that can recognize and bind to specific cellular receptors. The mechanisms of active targeting, such as receptor-mediated endocytosis, are saturable and nonlinear. Their effectiveness depends heavily on the concentration of the drug carrier complex, whereas passive targeting generally exhibits linear behavior over a wide range of doses. Biopharmaceuticals, which include protein and peptide drugs as well as nucleic acid drugs, require specialized delivery systems. This necessity arises because these drugs face significant challenges related to their stability and distribution within the body. One major obstacle is that biological drugs are often unstable when they are in the bloodstream and digestive system. To address this issue, modifications are frequently needed to enhance their stability or facilitate their delivery. Furthermore, these drugs are usually administered through injections rather than taken orally, as they tend to be too unstable to survive the digestive process and be effective when taken by mouth. The complexity of large macromolecules gives rise to distinct pharmacokinetic challenges. Due to their substantial size, such as monoclonal antibodies, which consist of over 1,200 amino acids, and their hydrophilic nature, these biologic drugs face limited diffusion into most tissues. As a result, their volume of distribution is often small and may be comparable to total plasma volume, since they tend to remain confined within the vascular space. Additionally, protein and nucleic acid-based drugs are rapidly broken down by endogenous proteases and nucleases. Early recombinant protein medicines often had very short half-lives, lasting only a few minutes. Another concern is immunogenicity, as these proteins can be recognized as foreign substances by the immune system. They may be actively engulfed by the reticuloendothelial system or trigger immune responses, especially if they are produced in non-human cells, which increases their potential to cause allergic or immunogenic reactions. Targeted delivery systems are crucial for biologics, functioning to protect the drug from degradation, decrease clearance, and improve transport or delivery to cells. The initial motivation for developing targeted delivery systems was primarily to improve the delivery of complex biologic drugs. However, these systems are also highly relevant for potent and toxic small molecule drugs, especially in the context of cancer chemotherapy. One of the main advantages of targeted delivery systems is the reduction of toxicity. Traditional drug delivery methods often result in the drug dispersing to non-targeted areas, which can lead to adverse side effects. By focusing the delivery to specific sites, targeted systems minimize exposure to healthy tissues. Many drugs used in these systems are highly reactive and potent, making their precise delivery particularly beneficial in cancer treatment. In addition to reducing toxicity, targeted delivery systems can enhance drug efficacy by addressing factors that influence how drugs are processed in the body. These factors include drug metabolizing enzymes and transporters that regulate drug disposition. For example, variants of the hepatic uptake transporter known as OATP1B1 can reduce the cellular entry of certain drugs, such as statins. This reduction can lead to higher levels of the drug in the bloodstream, increasing the risk of side effects like muscle damage. Conversely, variants of the efflux transporter BCRP or ABCG2 that decrease drug removal from the intestine may lead to higher plasma concentrations of the drug. Targeting agents, such as monoclonal antibodies, can enhance the therapeutic effectiveness of toxic drugs. These agents help direct the drugs to specific targets, potentially reducing side effects and increasing treatment efficacy. However, sources indicate that monoclonal antibodies are not the ultimate solution for drug targeting as once hoped. This limitation largely stems from their large molecular size, which reduces the total amount of active drug that can be safely and effectively administered. Consequently, The low ratio of drug to carrier limits the overall therapeutic potential of these agents. Developing targeted systems involves addressing several critical factors simultaneously. One important aspect is the characteristics of the target site, which include its anatomical and physiological nature, the permeability of its capillaries to large molecules such as biologics, and the mechanisms by which cells uptake substances. Additionally, it is essential to consider the physicochemical properties of the therapeutic drug itself, especially since many such drugs are large, unstable macromolecules. The physical and chemical properties of the carrier used to deliver the drug are also crucial, as they influence the system's effectiveness and stability. Moreover, ensuring the selectivity of the drug carrier complex is vital to target the desired site accurately, while also managing any impurities that could be toxic or trigger immune responses. Targeting a drug to a specific site in the body requires identifying a unique property of that site that sets it apart from other tissues. This unique characteristic can then be exploited in the design of the drug carrier, which helps to prevent adverse toxicity in other parts of the body. For example, humanized monoclonal antibodies are therapeutic proteins that have been engineered to be less immunoreactive. This design helps to partially overcome the problem of adverse immunological reactions that are often associated with protein carriers. The discussion of pharmacogenomics related to cytochrome P450 enzymes is essential within the broader context of factors that influence drug disposition. This includes the development of both traditional small molecule drugs and biopharmaceuticals. Although biopharmaceuticals, also known as biologics, are generally metabolized through mechanisms other than the cytochrome P450 enzymes, the significant impact of these enzymes on small molecule drug disposition remains crucial. This is especially important in the context of drug interactions and personalized dosing, as accurate prediction of drug response is necessary for all therapeutic approaches. Cytochrome P450 enzymes form a superfamily of heme-containing proteins responsible for metabolizing a wide variety of structurally diverse substances. These enzymes account for approximately 80% of all phase 1 drug metabolism processes. They play vital roles in drug detoxification, hormone metabolism, and the synthesis and elimination of cholesterol. Variations in the genes encoding these enzymes, known as genetic polymorphisms, lead to considerable differences in how individuals metabolize and eliminate drugs. Such variability can significantly influence treatment outcomes, emphasizing the importance of understanding these genetic differences for personalized medicine. Cytochrome P450 enzymes play an essential role in the process of drug biotransformation. This process is necessary because drugs are typically hydrophobic, meaning they do not dissolve well in water. To be effectively eliminated from the body, these drugs must be converted into more polar products that can be more easily excreted. Cytochrome P450 enzymes usually catalyze the rate-limiting steps in this process, which means they control the speed at which drugs are metabolized and eliminated. When there are genetic defects or variations in these enzymes, it can impair the body's ability to clear drugs efficiently. Such impairments can lead to the accumulation of drugs in the system, increasing the risk of toxicity. In the field of biopharmaceuticals, which includes large proteins and nucleic acids, the significance of cytochrome P450 pharmacogenomics mainly relates to how biologic drugs interact with other small molecule medications taken at the same time. Biologic drugs are generally eliminated from the body through mechanisms that do not involve the cytochrome P450 enzyme system. As a result, the likelihood of drug-drug interactions involving cytochrome P450 enzymes is lower when compared to small molecule drugs. Targeted delivery systems. Although cytochrome P450 enzymes metabolize small molecules, they also interact with key drug transporters such as organic cation transporter 1, which functions as a gatekeeper to the metabolism of positively charged drugs. These transporters, including organic anion-transporting polypeptide 1B1, P-glycoprotein, and breast cancer resistance protein, work alongside cytochrome P450 enzymes in the liver and intestine. Together, they determine the systemic exposure and effectiveness of administered drugs. Many potent agents used for targeted delivery, including biologics or toxic small molecules, are either substrates or inhibitors of these transporters. For instance, the immunosuppressant cyclosporin A small molecule used in transplant patients who may also receive biologic therapies, inhibits cytochrome P450 enzymes, as well as organic transporter 1B1, P-glycoprotein, breast cancer resistance protein, and multi-drug resistance proteins. Therefore, understanding the functionality of cytochrome P450 enzymes is crucial when administering complex therapies, even if the biologic therapy itself is not a substrate for these enzymes. During the process of biotransformation, the second phase involves reactions that facilitate the conjugation of metabolites produced in the first phase, or, in some cases, the parent drug itself. This conjugation occurs with highly polar endogenous molecules, which significantly increases the drug's solubility in water. As a result, the drug conjugates are more easily eliminated from the body through urine or feces, typically representing the final step in the body's drug removal process. The primary enzyme classes responsible for these reactions include uridine diphosphate glucuronosyltransferases, N-acetyltransferases, and glutathione transferases. These enzymes work together to facilitate the majority of drug clearance pathways, ensuring that most drugs are effectively removed from the body. Generally, there are fewer instances where pharmacogenetics related to phase 2 of drug metabolism dramatically affects drug clearance compared to phase 1 enzymes, such as cytochrome P450 enzymes. This is because phase 2 of drug metabolism possesses a significant reserve capacity, allowing alternative biological pathways to often compensate when specific phase 2 genes are defective. Nevertheless, when a phase 2 enzyme plays a crucial role in eliminating a drug or a toxic metabolite, and there are limited alternative pathways for its clearance, genetic variation in that enzyme becomes highly significant. Although therapeutic biopharmaceuticals, which include large proteins and nucleic acids, are generally eliminated through mechanisms such as degradation by endogenous proteases and nucleases or clearance by the reticuloendothelial system, studying phase 2 drug metabolizing enzymes remains crucial in this field. Conjugated biologics and antibody-drug conjugates are examples of modern biologics. These often involve linking a macromolecule, like a monoclonal antibody, to a highly potent or toxic small molecule. The fate and toxicity of the small molecule or its active metabolites, such as the metabolite SN38 derived from the chemotherapy drug irinotecan, are directly influenced by phase 2 enzymes such as uridine diphosphate glucuronosyltransferase 1A1. Biopharmaceuticals are frequently used alongside traditional small molecule drugs, especially in cancer therapy. For instance, monoclonal antibodies are combined with drugs like irinotecan or cyclophosphamide. Managing the risk of toxicity from these small molecules, such as neutropenia caused by irinotecan, requires pharmacogenomic insights from phase 2 metabolic enzymes to ensure the safety and effectiveness of the treatment regimen. While metabolism in phase 1, primarily involving cytochrome P450 enzymes, generally does not play a significant role in the elimination of large biologics, the transport of phase 2 conjugates, often polar metabolites of small molecules, depends on specific drug transporters. These include transporters such as multi-drug resistance-associated proteins 2 and 4, which facilitate the movement of conjugated compounds across cellular membranes for excretion. In essence, enzymes classified as phase 2 do not typically metabolize the complex structures found in biologic drugs. Instead, these enzymes are responsible for regulating the detoxification pathways for potent small molecules. These small molecules are often administered alongside or attached to biopharmaceuticals. Understanding the pharmacogenetics of these enzymes is crucial, as it plays a vital role in the comprehensive management of drug disposition in patients receiving advanced therapies. This knowledge helps optimize treatment effectiveness and safety by considering individual genetic differences that may influence how these detoxification pathways function. The effectiveness and safety of drug therapy depend on achieving and maintaining appropriate therapeutic concentrations at the site where the drug acts. Whether using traditional small molecule drugs or complex biological medicines, the success of treatment relies on this balance. Genetic factors, which influence how individuals respond to medications and are studied through pharmacogenomics, play a significant role in explaining variations between individuals. However, many other factors, both intrinsic and extrinsic, also impact how drugs are metabolized and distributed in the body. Understanding these various factors is essential for making informed clinical decisions. For example, adjustments in drug dosage can help prevent concentrations that are too low, leading to ineffective treatment, or too high, which can cause toxicity. Recognizing the interplay of genetic and non-genetic influences is crucial to optimizing drug therapy for each patient. Intrinsic factors are elements related to the patient's physiological condition. These include various aspects such as age, pregnancy, and ongoing diseases. Understanding these factors is crucial because they can significantly influence the patient's health and response to treatment. The relevance of biologic drugs to the field of biopharmaceuticals is significant, particularly concerning their stability and clearance within the body. Biologic drugs, which include proteins and nucleic acids, are inherently complex in structure and tend to be unstable once administered. They are also susceptible to rapid degradation by the body's own enzymes, such as proteases and nucleases. Intrinsic factors, such as inflammation, play a crucial role in this process. Inflammation, which is mediated by signaling molecules called cytokines, is known to suppress the activity of drug-metabolizing enzymes. Many therapeutic proteins used in treatment, including interferons and interleukins, function as immune modulators. These proteins are closely linked to cytokine pathways, which naturally regulate the activity of drug-metabolizing enzymes. Changes in systemic conditions, like inflammation or disease states, could further complicate issues related to the stability and clearance of these biologic drugs. Such changes may affect their efficacy and safety, emphasizing the importance of understanding these factors in the development and use of biopharmaceutical therapies. Targeted delivery systems are essential for the effective administration of biologics, as these therapies often face challenges such as poor tissue penetration and rapid clearance by the body's reticuloendothelial system. To address these issues, sophisticated delivery vehicles like liposomes and nanoparticles are commonly employed. These targeted systems take advantage of physiological changes caused by disease states, such as cancer, which can alter characteristics like vascular permeability. This phenomenon, known as the enhanced permeability and retention effect, enhances the accumulation of these delivery systems in diseased tissues. The success of such targeted delivery methods heavily depends on the environment within the body, which can be modified by the presence of disease or the concurrent use of other foreign substances. Although biologic drugs are typically eliminated through mechanisms that do not involve cytochrome enzymes, making interactions with small molecule drugs less likely, the reverse is not true. Therapeutic proteins can influence the activity of drug-metabolizing enzymes, which means that co-administration of a therapeutic protein with a small molecule drug could potentially lead to drug-drug interactions. Furthermore, many biopharmaceuticals are part of complex treatment plans, such as monoclonal antibodies used alongside chemotherapy. This complexity highlights the importance of thoroughly understanding all factors that can influence drug disposition to ensure safety and efficacy. The inherent variability and complexity of biological products mean that achieving true identicalness, which is a hallmark of chemical generic drugs, is often impossible. The Food and Drug Administration recognizes that even genetically identical recombinant drugs can differ due to variables in the cell clone, purification processes, storage conditions, and formulation methods used by different manufacturers. As a result, biological generics are officially termed biosimilars. The regulatory pathway for biosimilars was established under the Biologics Price Competition and Innovation Act of 2009. This law created an abbreviated licensing process for products that are demonstrated to be similar to or interchangeable with a biological reference product that has been licensed by the Food and Drug Administration. The concepts of pharmaceutical equivalence, bioequivalence, and therapeutic equivalence define the criteria required to demonstrate that a multi-source drug product is clinically interchangeable with the original innovator drug. Understanding the precise relationship among these definitions is essential for ensuring patient safety and the effectiveness of medications when generic substitutions are made. Pharmaceutical equivalence is a fundamental concept that determines whether two drug products are identical in terms of their chemical composition and physical properties. This comparison helps to establish that the drugs are equivalent in their makeup, ensuring consistency and reliability in their use. By confirming pharmaceutical equivalence, healthcare providers and regulatory agencies can ensure that different formulations of the same medication will perform similarly when administered to patients. For generic drug products to be considered pharmaceutical equivalents, they must meet specific criteria established by the Food and Drug Administration. Firstly, they must contain identical amounts of the active pharmaceutical ingredient, which means the same salt or ester of the same therapeutic molecule. Different salt forms or prodrugs of the same active ingredient do not qualify as identical and are instead classified as pharmaceutical alternatives. Secondly, these drugs should be in the same dosage form to ensure consistency. Additionally, they must deliver the same amount of the active pharmaceutical ingredient over the same dosing period. Lastly, they need to meet the same standards regarding identity, strength, quality, and purity. This includes meeting applicable standards for potency, content uniformity, disintegration times, and dissolution rates where relevant. Flexibility within pharmaceutical products that are considered pharmaceutically equivalent allows for differences in their inactive ingredients, known as excipients. These can include substances such as colorants, flavors, and preservatives. Additionally, there may be variations in characteristics like the shape of the product, whether tablets are scored, the mechanism by which the drug is released, packaging details, and the levels of impurities present. These impurities must fall within an acceptable range. However, it is important to note that even minor differences in excipients, impurities, particle size, or the manufacturing process can sometimes lead to unforeseen issues that affect the product's therapeutic performance. Bioequivalence is a pharmacokinetic measure used to determine whether the active ingredient in a generic medication functions similarly to that in the original or innovator medication once inside the body. It indicates that there is no significant difference in the rate at which the active component is absorbed or in the extent to which it becomes available at the site of action. Such a comparison should be conducted when the products are administered at the same molar dose and under similar conditions within a properly designed study. The focus of bioequivalence testing is on two main aspects: the rate of absorption and the total amount absorbed, known as the extent. If there is an intentional difference in the rate of absorption, for example, in certain extended-release formulations, the products can still be considered bioequivalent. This is acceptable if the difference is reflected in the product's labeling, is not medically significant for the drug's effectiveness, and does not significantly impact the overall extent of drug availability. Bioequivalence studies generally compare pharmaceutical equivalents or pharmaceutical alternatives to establish this similarity. Therapeutic equivalence is a key regulatory classification required for a generic drug to be substituted for a branded drug without needing permission from the prescriber. A generic drug is considered therapeutically equivalent to the original branded drug if it meets two essential criteria outlined during the abbreviated New Drug Application process. These criteria can be summarized as the product having comparable pharmacokinetic properties and being sufficiently similar in composition to ensure similar therapeutic effects. For a generic drug to be assumed as therapeutically equivalent, it must be approved as safe and effective. Additionally, it must be a pharmaceutical equivalent, meaning it contains the same active ingredients, strength, dosage form, and route of administration as the original drug. Furthermore, the generic must be bioequivalent to the innovator drug. Bioequivalence implies that there are no known or potential problems with the formulation that could affect its bioavailability. If any issues are present, they must be demonstrated to meet appropriate standards through specific testing. Finally, the product must be properly labeled and manufactured in compliance with current good manufacturing practices regulations, ensuring quality and safety. The substitution of innovator drug products with TE generic drug products by a pharmacist is permitted under the full expectation that the substituted product will produce the same clinical effect and safety profile as the prescribed product. Challenges to the relationship between pharmacopoeial equivalence and bioequivalence. While pharmacopoeial equivalence and bioequivalence are often assumed to ensure therapeutic equivalence for small molecule generic drugs, this assumption is not flawless. Several factors can undermine this relationship. One such factor is the quality differences in active pharmaceutical ingredients. Although pharmacopeal standards require these ingredients to be chemically identical, they can differ significantly in physical properties such as particle size, crystalline form, impurities, and stability. Variations in the synthesis process can lead to different impurity profiles, which in turn can affect the drug's stability. Poor stability caused by formulation differences may result in rapid degradation and therapeutic failure, even when the products are chemically equivalent. For example, generic cefuroxime has experienced such issues. Differences in excipients, the inactive ingredients, and manufacturing processes can also impact drug performance and stability. These differences may occasionally lead to therapeutic non-equivalence, meaning that the generic and the reference drug do not perform identically in clinical settings. When it comes to complex products like biologics, biotechnology-derived drugs such as proteins and peptides, establishing pharmaceutical equivalence and bioequivalence becomes particularly challenging. These products must demonstrate both pharmaceutical equivalence and comparable pharmacodynamic activity. Additionally, differences in impurities within biologic products might trigger immunogenicity problems, which can have serious clinical implications. Consequently, the pathway for biosimilars, biologic products highly similar to already approved biologics, was created. This pathway requires demonstrating a high degree of similarity and no clinically meaningful differences across multiple domains, including immunogenicity, rather than relying solely on pharmacopeal equivalence and bioequivalence assumptions. Pharmacokinetic equivalence and bioequivalence are essential regulatory and scientific requirements for generic small molecule products. They allow for the assumption of therapeutic equivalence. However, ongoing scientific advancements are necessary to potentially strengthen bioequivalence requirements for high-risk products, thereby reducing the known incidence of therapeutic non-equivalence. For a product to be considered a biosimilar by the Food and Drug Administration, it must meet certain criteria based on the total evidence provided by the sponsor. The main requirements for biosimilarity include demonstrating high similarity to the reference product, allowing only minor differences in components that are not clinically active. Additionally, there should be no clinically meaningful differences between the biosimilar and the reference product concerning safety, purity, and potency. To establish biosimilarity, evidence must be gathered across various domains such as the structure and function of the product, animal toxicity tests, pharmacokinetics and pharmacodynamics in humans, immunogenicity, and overall clinical safety and effectiveness. The manufacturing process for both products is also evaluated. Particularly, immunogenicity must be assessed through at least one clinical study. When it comes to products that are interchangeable with the reference product, they must meet the same biosimilarity criteria and also fulfill additional conditions. The interchangeable product is expected to produce the same clinical result as the reference product in any patient. Moreover, for products administered multiple times, switching between the interchangeable product and the reference should not pose greater risks or reduce efficacy compared to using the reference product alone. The development and approval process for biosimilars recognizes the scientific and technical challenges associated with large and complex biological products. Unlike small molecule generic drugs, which require proof of pharmaceutical and bioequivalence to assumed equivalent therapeutic effects, biosimilars are subjected to a different standard. This standard emphasizes their high similarity to the reference product and the absence of clinically meaningful differences, assessed through a comprehensive, step-by-step evaluation of their structure, function, safety, and clinical performance. The landscape of pharmaceutical science is increasingly dominated by biopharmaceuticals, also known as biologics. These represent the fastest-growing class of complex, high molecular weight drugs that are derived through biotechnology. These molecules include protein and peptide drugs, such as monoclonal antibodies, as well as nucleic acid drugs, including gene therapies and antisense oligonucleotides. Their size and instability present significant challenges in both their development and clinical use. The fundamental challenges of biologic drugs are significant. Unlike chemically simple small molecules, such as aspirin, which weighs approximately 180 daltons, The therapeutic function of protein-based drugs depends entirely on maintaining their complex four-tiered structural hierarchy, which includes primary, secondary, tertiary, and quaternary structures. Degradation processes, such as cleavage by endogenous proteases or nucleases, can quickly lead to the loss of the drug's activity. In addition, pharmacokinetic limitations pose further challenges. The large size and complex nature of these biologics create specific issues related to their movement and distribution within the body. Typically, biologic drugs are too unstable to be taken orally because they are rapidly digested in the gastrointestinal tract, as seen with insulin. Therefore, they must be administered through parenteral routes, such as intravenous infusions or subcutaneous injections, to avoid degradation in the gastrointestinal system. Furthermore, their size restricts their ability to diffuse into tissues, confining most of the drug to the vascular space. This limitation results in a small volume of distribution, which affects how widely the drug can spread throughout the tissues. Targeted delivery systems are designed to improve the efficiency and effectiveness of drug administration. To achieve this, they focus on ensuring the structural stability of the drug, reducing rapid clearance from the body, and enhancing targeted delivery. One common technique is chemical modification, such as attaching polyethylene glycol to the drug molecule. This process, known as polyethylene glycol conjugation, helps extend the duration of the drug's circulation in the bloodstream by allowing it to bypass filtering organs like the kidneys. Additionally, drugs can be encapsulated within various carrier systems, including liposomes, polymer-based systems, and nanoparticles. These carriers not only facilitate better transport of the drug to its target site, but also protect the drug from degradation before it reaches its destination. Delivery systems are also classified based on their level of specificity. The first level, called first-order targeting, involves directing the drug to specific organs or tissues. The second level, second-order targeting, focuses on targeting particular cell types within these tissues. The third level, known as third-order targeting, involves directing the drug to intracellular sites, such as entering cells via receptor-mediated mechanisms. Monoclonal antibodies are highly specific protein drugs that are extensively used as targeted delivery agents for drugs. They function as homing devices, especially in the context of antibody-drug conjugates. An example of such a conjugate is trastuzumab emtansine, also known as TDM1. One major limitation of using monoclonal antibodies as carriers is their large size, approximately 148,000 Daltons. This significant size greatly reduces the drug-to-antibody ratio, which measures how much active drug can be delivered per antibody molecule. In the case of trastuzumab emtansine, the large size of the antibody carrier means that over 98% of the total administered mass is composed of the antibody itself rather than the active cytotoxic payload. The payload in this example, DM1, weighs around 738 Daltons. This imbalance limits the efficiency of dosing because the majority of the administered substance is the carrier rather than the active drug. This class of biologics requires specialized delivery systems to overcome issues of instability and to facilitate the uptake of the molecules into cells. Gene therapy involves the delivery of recombinant DNA through viral or non-viral vectors into somatic cells. This process enables the cells to produce therapeutic proteins that can help restore defective biological functions. For example, a specific viral vector used in therapy is a type of adeno-associated virus. Antisense oligonucleotides are synthetic strands of nucleic acids designed to bind complementarily to target messenger RNA. By doing so, they inhibit translation or modulate the splicing process, which can block defective genetic pathways. RNA interference is a mechanism that uses small interfering RNAs to silence gene expression. These molecules utilize a complex called the RNA-induced silencing complex to locate and cleave target messenger RNA, leading to effective gene silencing. This overview highlights how different nucleic acid drugs are delivered and function within biological systems. Disposition and pharmacogenomic considerations are vital aspects of therapy management. While biologic therapies are generally eliminated through mechanisms other than cytochrome enzymes, evaluating pharmacogenomics remains important because these advanced treatments are often used alongside traditional small molecule drugs or carry small molecule payloads. Genetic variations, or polymorphisms, in drug-metabolizing enzymes such as cytochrome P450 family enzymes, and phase II enzymes like uridine diphosphate glucuronosyltransferases and N-acetyltransferases play a critical role. These variations influence the toxicity and efficacy of chemotherapy agents or small molecule drugs incorporated within antibody-drug conjugates. Additionally, drug transporters, which regulate the movement of foreign compounds, are essential for drug disposition. Transporters, such as organic anion-transporting polypeptide 1B1 and breast cancer resistance protein, can impact the exposure and effectiveness of both small molecule drugs and targeted delivery components. Furthermore, non-genetic factors such as disease status and inflammation can significantly alter physiological conditions, including cytokine levels, which affect drug metabolism and the success of targeted therapies. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.